Previously in Rad Bio Review, we went over sections 1, 2, 3, 4, 5, and 6. And now our journeyers find themselves finally past many of the pathways and now getting into more clinical aspects of radiobiology, and they couldn't be more excited. So we will begin with section 7, which is normal tissues, radiobiology, and we only have 3 more to go after this. So this section is on what is clinically relevant with regards to normal tissue response to radiation. So early responding tissue, high alpha beta, fraction size is only somewhat important, but the overall treatment time is important. For late responding tissues, think low alpha beta, and the fraction size totally determines the late effects. And the treatment time is not really that important, but that's not considering flash. We talked about ISO effect curves and how here in red we have steeper curves for things with late reactions compared to shallower curves for things with early reactions. And there's this thing called the law of Burgoni and Tribondieu, which is that cells are more sensitive to radiation if they're in mitosis. If they are rapidly dividing cells, spending more time in mitosis, and if they are poorly differentiated. The one exception of this is mature lymphocytes, which, despite being cells that have already completed mitosis, they're still very radiation sensitive. There's something called the class system rank, the Casaret's class system rank, which was a way of classifying cells from most radiosensitive, class 1, to least sensitive, class 5. And these were named vegetative cells, rapidly dividing undifferentiated cells with a short lifetime, most radiosensitive, and these include these types of cells highlighted here. Then there are class 2. These are called differentiating intermitotic cells. These are actively mitotic, more differentiated. And these include these types of cells. So now we have spermatocytes, type B spermatogonia. Then class 3, so intermediate, is multipotential connective tissue cells. They divide irregularly, and endothelial cells and fibroblasts are an example of this. And then class 4 is reverting postmitotic cells. So these cells do not normally undergo mitosis, but under specific circumstances, if they're stimulated, they're forced to divide. They tend to be long-lived and are more differentiated than those above. And these include these kinds of cells: liver, kidney, pancreas, sweat glands, endocrine glands, interstitial cells, and mature lymphocytes. And then class 5, least radiosensitive, these are called fixed postmitotic cells. They don't divide, they're highly differentiated and resistant to radiation. So you guessed it, nerve cells, muscle cells, and RBCs. So these have acronyms: VIM, DIM, RPM, FPM. If you look at this figure, you can see some of these are being referred to here. So that's just so you guys can interpret this. There is something called the histohematic barrier, which is a structure located between the blood and the tissue that regulates the metabolic process between them. So this is kind of showing like what's happening to these kinds of cells when we give radiation. So like these kinds of cells respond, they get smaller, and then there's sloughing, and then there's recovery, and these lineages sort of grow back. Um, and uh, yeah, somehow this came up. So now you can sort of understand what it means. There is something called the Mikulowski's classification. So this also comes up. You'll see it in the flashcards that you guys have, um, and in questions that are kind of old school. Basically ask you like, uh, which of the following is an example of like an H-type cell, or which of the following is a type of F-type cell. And so H-type are hierarchical. These are stem cells that progressively differentiate to functional cells. Includes the hematopoietic system, intestinal epithelium, epidermis. These tend to mostly be early responding tissues. And then there's F-type, flexible tissues of stem cells that don't have a strict hierarchy and can be triggered to divide by damage to the tissue or organ, including functional cells. So liver, dermis, and thyroid. And many tissues are a hybrid of these two models. So two different ways to think of how you categorize cells, either with this Casaret's class system or the Mikulowski's system with the H and the F. There was a section about re-radiation that I didn't really see about. I think you know everything that you need to know about re-radiation just from clinic experience. So nothing exciting to share here. Mechanisms of normal tissue responses. So they wanted you to study molecular and cellular responses and slowly and rapidly proliferating tissues. So let's talk about blood. So here we saw that like RBCs were the least radiosensitive. And then there was this thing about lymphocytes being very radiosensitive. So when you look at someone's blood counts after getting radiation, what are you going to see? First, you'll see lymphocytopenia. Then you'll see granulocytopenia, and then thrombocytopenia, and then finally anemia. The way I interpret this clinically is that like, yeah, radiation can affect red blood count and platelets, but really if someone's coming with low platelets, like, or low hemoglobin, it's probably from their chemotherapy. And like radiation is probably not going to do that much. Radiation is mostly affecting like lymphocytes. So I thought that was kind of interesting. I think sometimes we overreact when someone has low platelets, but I don't think it's our fault. Especially if you consider the timing. Like anemia takes like, I think like months after radiation. Um, so if someone has anemia while they're on treatment, it's probably not from radiation. Kidney cells also are not very radiosensitive. However, the kidneys are delicate because if you destroy a subunit, it can't repair. So they don't tolerate re-irradiation very well. Fractionation helps spare the kidney from damage, and the kidney has little or no tolerance to re-irradiation. This is interesting. I don't think we think about this maybe as much as we should when we're in clinic. Skin. The epidermal layer is damaged early, and the dermal layer is damaged late. It's like, think about this. Like, is your mind blown? Because for skin, like we see some things are like acute early reactions, and other things are like late reactions. Those are just kind of random. So it has to do with like what part of the skin is being damaged. Um, Lastly, when there's moist desquamation, it's not considered dose dependent. Rather, it's relying on what is the cell repopulation. So this is why two people that get the same dose could have really different reactions if one person's doing skincare and the other person isn't doing skincare. Spleen, uh, late effect, decreased size, fibrosis, thickened capsule, and obliteration of the sinusoids. Radiation fibrosis, what's happening? There's TGF-beta signaling, which drives fibrosis. And there's something called connective tissue growth factor. TDGF signaling calls myofibroblasts to initiate collagen and extracellular matrix production. Reactive oxygen species, these contribute to perpetuation of injury and further activate TGF-beta. And then there's angiotensin signaling. Acute radiation injury. So TGF-beta again comes in. The majority of patients who have pneumonitis will progress to fibrosis. So I think this point was like how much acute injury you get sometimes correlates with what your late injury is going to be. So the other way is like if someone got fibrosis later on, they probably did have pneumonitis earlier on, but it might have just been clinically silent. I don't remember being asked specifically what these doses were, so I don't think you need to know them. And then we had some nice review in some of our rad bio lectures where we just talked about what are adverse tissue responses for skin, blood, intestines, kidney, lung, testes, lens, spinal cord, and liver. Again, I don't think we were really on what these doses were, but I just thought this was interesting. As you're trying to understand how do different tissues respond, you can see kind of some different dose thresholds. It's still unclear to me exactly what fractionation these doses are in. I think that some experiments look at just a single dose, and then they look at what's the effect after that single dose. And then if you fractionate something, it's going to be more gentle. So I guess what you could say is that like something as low as 5 gray could cause early erythema. But if you fractionate that, you know, maybe it's not as likely compared to if it's a single dose. Or I guess, or vice versa. So it's like, it's actually not super helpful when you don't know the dose fractionation, in my opinion. Okay. Mechanisms underlying clinical symptoms. So I think these are worth knowing about. For the spine, there's something called Lermid's sign. I'm not sure if I pronounced that correct. This is something that where a patient noticed like a shock-like sensation in the spine and extremities, usually symmetrical, and it's exacerbated by neck flexion. It resolves on its own, but if you had a patient a couple months after some sort of spine radiation having these symptoms, you could provide maybe reassurance, or you could be reassured yourself. It happens after doses as little as 35 gray with conventional fractionation, and it's due to transient demyelination. This is different than true radiation myelopathy, which usually appears as a progressive myelopathy or motor neuron syndrome. Most commonly is progressive myelopathy, which kind of begins as brown Sicard and then progresses over weeks to months until it causes paraparesis or quadriparesis. On the other hand, motor neuron syndrome um, has been observed in pelvic radiation for testicular tumors, and it's muscle weakness, atrophy, fasciculations, and areflexia. There tend not to be sensory, sphincter, or sexual changes. They progress over months to years and eventually stabilize. This did not come up, but it was involved in practice questions. Liver. This is very important to know about as a radiation oncologist. Radiation-induced liver disease typically occurs between 2 weeks and 3 months after radiation. You notice ascites, elevated liver enzymes, and hepatomegaly in the absence of jaundice. You can have suprahepatic vein obstruction and veno-occlusive liver disease, and killing of vascular endothelial cells seems to be of greater importance than hepatocyte cell death in the process of RILD. Tissue kinetics, so functional subunits, just kind of a definition. And I guess that has to do with how a tissue is organized. It's organized in functional subunits, and functional subunits can be repopulated by surviving cells. Also, cells can migrate from a next door neighbor functional subunit. Wound healing has been described in 3 steps: inflammation, proliferation, and remodeling. Okay. This next part, we're going to get into some doses that you do need to know. I think by the end of studying, you'll actually be pretty familiar with a lot of these things. So this is a key figure. With total body radiation, there's something called prodromal radiation syndrome, which is where you don't have appetite, of nausea, and vomiting. And then there are acute radiation syndromes, which are sort of dose related. It's summarized here. At this dose range, you can have heme syndrome. And since your lymphocytes are going down and your immune system is going down, you're at risk of infection and possibly risk of bleeding with low platelets. Then there's something called radiation-induced hypotension, which can occur in the 6 to 8 gray range. And then GI syndrome. This one's really important. You can die within 1 or 2 weeks after GI syndrome. Whereas with heme syndrome, since like we talked about, the death of these blood components takes a little bit, there's more of a latency, and it might be like 1 or 2 months before you're actually having an infection. GI syndrome, you can die within 1 to 2 weeks. And may want to consider bone marrow transplant in this dose range to try to help the patient. And then there's this, anything over 10 gray, now you're in this like super dangerous range, where if they have a question where it's like, oh, someone was standing around and then a bomb went off, emitting radiation dose, and then they noticed they like felt bad, they had like nausea and vomiting, and then they had immediate diarrhea. Like, what do you think happened? How much dose do you think they got? Or like, what should you do? So that'll be a typical, yeah, the same kind of like, oh, someone got exposed to something and then these were their symptoms. What should you do? Or what do you think it is? And then lastly, the highest dose, I just think of it as like their brain is exploding, but you have blood-brain barrier damage above 20 gray, cerebral edema, vasculitis, and necrosis. And that is also lethal. This is a number summary of these different syndromes, what's actually happening, what are some of the symptoms, and what's the timing of when they're at risk of death. Um, Here, the doses are given in gray, and they represent gray of X-rays. Lethal dose, so the LD50, if you give antibiotics in nursing care, you can stretch what the lethal dose is. That makes sense? So like someone might die with 3.5 gray without any care. But if you do have care, that threshold to death might be 7 gray. And then furthermore, if you have like blood transfusions and granulocyte colony stimulating factor, you can increase that LD50 to 9 gray. Where do we see blood transfusions and GCSF come in? That's I think um, here. So we talked about antibiotics, transfusions, antiemetics, nutrition, growth factor. Okay. Acute GI side effects are first due to inflammation, cytokine release from radiation. Then there's crypt cell killing days later, and then eventually total villi loss, a loss of absorptive ability. So yeah, a handful about this. This is a very popular topic. Next, sterility. So this is also a popular topic. So gonads, male testes. I mentioned in passing that there's type A spermatogonia and there's type B spermatogonia. Type A is either dark or pale. It starts out as a spermatogonia stem cell and then undergoes mitosis to produce one of these three types of cells. If it's a type A dark cell, that is a self-renewing system. So that's responsible for repopulation after radiation exposure, and these are the least sensitive to radiation. Type A pale cells, these will undergo mitosis to produce type B cells, and type B cells are what differentiate into spermatocytes. Here's a diagram kind of showing what I just described. Spermatogenesis takes 70 days or 10 weeks, or 2.5 months. Okay, and spermatocyte and spermatid lifetime is 46 days. The latent period to azoospermia could be 6 weeks. So spermatogonia die right away because they're the most radiosensitive. And then you just have to wait 46 days for all the other spermatocytes and spermatids to die. This is kind of showing, so after we go from spermatogonia to type B cells into spermatocytes, then there's meiosis 1 to get spermatids, and then meiosis 2 to get spermatozoa. Okay. Infertility, it manifests when there are no more spermatozoa. So you can see there's a latent period between irradiation and sterility. Um, at a dose of 0.15 gray, you get oligospermia and reduced fertility, and you recover in 9 to 18 months. At half a gray, you get azoospermia and temporary sterility. And again, a 6-week latent time until it happens. And then 2.5 to 3 gray, uh, this is in a dose that's fractionated over 2 to 4 weeks. That can result in permanent sterility. So we use this kind of for our like critical dose thresholds for the gonads because we want to avoid permanent sterility. This is in a fractionated dose scheme. How about in a single dose? 6 gray in a single dose leads to permanent sterility. And then here's just some other single dose ranges. 2 to 3 gray in a single dose, temporary sterility, and recovery takes about 1 to 2 years. 4 to 6 gray in a single dose, temporary sterility, but recovery can take up to 10 years. Radiation sterility does not produce hormonal changes. So I think this is important, or like if patients ask, because testosterone production and things like that, you have adrenals and other parts of the body. Okay. Lastly, Leydig cells. So these are some of the support cells. They're not actually part of the spermatogonia lineage, but Leydig cells, they can tolerate 20 gray in prepubertal boys and 30 gray in men before testosterone is affected. Okay, so I guess I mentioned adrenals, but I probably should have mentioned Leydig cells also being important for testosterone. Cool. Um, Females, uh, this is I think it in a nutshell. So all our ovaries are produced by 3 days of birth. All the cells have progressed to the oocyte stage. You're born with about 1 million oocytes, and then it declines to 300,000 by the time you reach puberty. And this explains why there's a difference in dose for how much dose you need to give before a female is sterile. So if it's pre-puberty, the dose is 12 gray to cause sterilization. But if it's post-puberty and premenopausal, the dose could be as low as 2 gray. I think that makes sense. Sort of. The more cells you have, the more dose you need to cause sterility. What doesn't make sense is if you think of like, what's the D0 and like, oh, every certain amount of dose causes like a 10% cell kill. Like this difference is like almost like same order of magnitude. So to me, this kind of didn't really exactly line up because this is like 6 times difference in dose. So you might think there's like a 10 to the 6 difference in the number of cells. But I didn't find any nice explanation about that. So I think you should just accept these numbers and accept these numbers. In females, radiation sterility does produce hormonal changes and it causes things like menopause. And then lastly, there's no latent period for female ovary radiation. Okay. Lastly, immunologic effects. So if you have TBI of 3.5 to 4 gray, that inhibits the immune system. You'll see that up in the figure earlier. Assessment and treatment of radiation accidents. This is also important. I think you'll get on this or two. First, address open wounds. Then you address their nose and mouth where there could be inhalation or ingestion of radioactive materials. So if they have like a bunch of powder on their face, like wipe it off. Um, then address intact skin that could be exposed. So check their skin and wipe their skin off, or like if their clothes are drenched in like some radioactive paint, like take the clothes off. But you want to do it in this order. Very specific about that. Okay, examples of radiation mitigators. So these help mitigate radiation damage after exposure. So we talked about GCSF, which can help save people. Prussian blue. This is another thing that if someone ingested a radioactive source, Prussian blue in the gut helps trap radioactive cesium and thallium to keep them from being absorbed by the body, and then you poo it out. And then ACE inhibitors to help prevent radiation-induced nephrotoxicity. So you mentioned you may have heard I mentioned angiotensin earlier. So this is where ACE inhibitors come in. Okay. So yeah, Prussian blue, this is a good one to remember. Bone marrow transplantation is another thing that can be used to rescue people when they have hematopoietic radiation toxicity. Although these days, like GCSF is a common approach. Any questions? Okay. Next, dose fractionation and tumor control probability curves. So I mentioned this last session about Poisson statistics. And so here we have a formula, e to the negative n equals p, where p is the probability of curing patient, meaning that there's going to be 0 surviving cells. And n is the average number of surviving cells. So if I give a treatment that says like, on average, this thing kills whatever, 99%, what's the chance that I'll actually kill like all of them? And that chance would be e to the negative n. Okay, so tumor control probability of a certain dose. This is a calculated dose at which XX% of the tumors are permanently controlled over the follow-up time that's been previously determined to detect all the vast majority of tumor recurrences. Okay, so for 1 cell remaining from the tumor, P equals 37% because we had e to the negative 1 equals 0.37. So the tumor control D37 is the dose that would leave 1 cell of the tumor. Other example, TCD90 is the dose that would leave 0.1 cells from the tumor. TCD95 is a dose that would leave 0.05 cells from the tumor. TCD99 is a dose that would leave 0.01 cells from the tumor. For very small X in the formula, we get e to the x equals 1 plus x. So this is some of the Maclaurin series, and this rule of thumb can be helpful. I've also graphed this here so you can just see what the curve looks like. And so let's look at some example questions using this new formula. So a tumor has 10 to the 6 cells. Its effective dose response curve has been determined for dose fractions of 2 gray per day and is characterized by a no shoulder and a D0 of 2.5 gray. What is the total dose required to give a 37% chance of tumor cure? So note they threw out 37%, and you might recognize like, oh, this is e to the negative 1. So they're asking about the chance of leaving one cell from the tumor. So the answer here was E, 35 gray. Let's see how they did that. So again, I mentioned that they're asking for the dose to have just on average one cell surviving. And here they have the number of cells you start with times the surviving fraction. So in this case, we started with 10 to the 6 cells. And so the surviving fraction that we needs to be, I guess, 10 to the negative 6. That way we get 10 to the 6 times 10 to the negative 6 equals 1, and we have e to the negative 1. So now that we know we want the surviving fraction to be 10 to the negative 6, we see, okay, since the survival curve is exponential with the D10 of 5.75 gray, so here they did D10 equals D0 x linear log, or natural log 10. So here we had D0 was 2.5 gray, and then natural log 10, I guess, is 2.3. I guess this is a times sign, sorry. So that's how they get this 5.75 gray is D10. And since we want to do 10 to the negative 6, that's going to be, if this is like a 10 to the negative 1, we want to do that 6 times. So we multiplied this times 6 to get this, which was closest to E. So that was a hard question. I think it combines a couple things. Based on the same parameters as the previous question, what additional dose must be added to still achieve a 37% chance of cure if the clonogens in the tumor went through 3 cell divisions during treatment, assuming no cell loss? So 3 cell divisions, that's times 2 times 2 times 2. So that means there's 8 times more. And so you want to see, you want to account for that. And so this is how they did it. Okay. I'll let you guys review that more on your own, but these are examples of tricky questions. Okay. Normal tissue complication probability curves. You guys have probably seen this. We have a nice dose range where we're maximizing the therapeutic ratio, meaning we're getting a lot of tumor control and we're getting minimal tissue damage. It's a sigmoidal shape for both of them. Causes of treatment failure. So the way I interpreted this is like you're on the tip of a sword. Treatments are supposed to be at a very sweet spot where tumor control is high and tissue damage is low. If you go a little to the left, your tumor control gets a lot worse. And if you go a little bit to the right, your tissue damage gets a lot worse. So we're always dancing on the sweet spot. That's why physics QA is so important. Like if our measurements are off by even just 10%, it could be really detrimental. Time, dose, and fractionation. So here's where I finally introduced the 4 R's of fractionation: repair, redistribution, reoxygenation, repopulation. Repair takes 1 to 4 hours, and rule of thumb, don't radiate within 6 hours. Redistribution takes 4 to 8 hours. Reoxygenation can take hours to days, like 1 to 4 days. And repopulation for early responding tissue can be 2 to 4 weeks. For late responding tissue, it can be months. And accelerated repopulations is like one of my favorite concepts because it explains why it's so important to complete treatments for fast-growing cancers within a certain time after you've started the clock. So for cervical cancer, cells start to accelerate how fast they're repopulating at about 19 or 21 days. And for head and neck cancer, this starts at about 28 days. Rule of thumb, I say 3 weeks. Another way to interpret this is like any treatment that you're doing where the treatment is less than 3 weeks, accelerated repopulation isn't going to be a factor. So when we do like SBRT treatments, it doesn't really matter, in my opinion, whether or not they're going every other day, every other day. You even see sometimes for break-even spacings out by 1 week, because all of that's within such a short time span that accelerated repopulation hasn't begun to happen. The last cool thing about accelerated repopulation that you may have already realized is that when we give induction chemotherapy, unfortunately, a lot of times now we're having to battle against accelerated repopulation because we've started the clock, and then sometimes by the time the patient gets to us, those cells are already undergoing accelerated repopulation. That's why I think why a lot of induction chemotherapy versus concurrent chemotherapy trials don't look as good. What's the radiobiologic rationale behind dose fractionation? Allows normal tissues to repair, allows cancer cells to redistribute, and give time for reoxygenation of cancer cells, and make sure you finish treatment fast enough before repopulation interferes with how effective the treatment will be. Effect of tissue and tumor type on the response to dose fractionation. So we talked about alpha beta ratios. It's based on the response of tissue to different forms of radiation. If it has a low alpha beta, it has good sublethal damage repair. If it alpha beta ratio can change depending on the type of radiation used. For instance, alpha beta ratios for tissues is higher with neutrons, high LET compared to protons. This is interesting. I don't think we actually talk about it very much, probably since we almost always use photons. I don't think there are any saying like, what's the alpha beta ratio of the rectum with carbon ions? So, okay, here is an example question I thought was worth showing. I think you guys can just look at this on your own, but it's here. Here's some approximate alpha beta ratios for different organs. Next, quantitating multifractional survival curves. I didn't find anything related to that in my studying, so I left it blank. BED and ISO effect dose calculations. This is really important. hopefully by the time you guys finish your like rad bio studying, you'll feel comfortable using this in clinic. Super helpful. And I have a spreadsheet if you guys want and you don't already have your own spreadsheets, just let me know and I can send it to you. It's what I do to figure out like what's an equivalent dose with a different fractionation to get the same BED. And then if you want to account for proliferation during treatment, you have this component too, which I think would come into play if someone had like a significant treatment delay, like linear accelerator broke for a month and now they're coming back. Are you going to give them extra dose to account for this, BED that you need to make up for? Or yeah, if they just skipped a week because of personal issues, would you adjust the dose? And then this is another question. I'll zoom in so you can see it a little bit better for the sake of time. Okay, hypofractionation. So if you notice this curve, like, and you followed it, at a certain point, you get to where the survival is 0. But we know we don't have like a perfect treatment with just if the dose is like around here. So what this is saying is that this curve is actually probably wrong for really high doses because we're not like over here. So most likely what this should look like is it like goes down and then at some point it should probably be more straight. So you just have to recognize that BED calculations with the linear quadratic model fall apart once you get to high dose per fraction. About 6 gray per fraction is where it doesn't work as well. So there are other ways to calculate this, which it doesn't go into, but if you're curious, there's something called the single fraction equivalent dose, which is pretty cool. And in my Excel sheet, I show calculations for this, which is pretty neat. Okay, brachytherapy. Dose rate effects. There were no questions on this in my studying, so I left it blank. I guess you could imagine that some would say like a high dose rate has some stronger BED. It's unclear if that's actually making a difference with HDR and LDR, according to my understanding. Choice of isotopes. So this will be covered in your physics studying. So I left this section pretty blank. Radio-labeled antibodies. I guess there was one example I found that I put in here. Iodine 131 is a tositumumab. It's a radio-labeled antibody against CD20 in B-cell non-Hodgkin lymphoma. Radiobiologic aspects and different radiation modalities. So they wanted you to know about protons and high LET sources. So what did I put here? First I talked about silicon ions. These have the highest RBE, 3.5, and the lowest OER. Neutrons have RBE of 2, OER of 2-ish, and hydrogen ions, also known as protons, and helium ions have RBE of 1.1, and OER is around here. This is actually pretty much a repeat of this section here. So you don't need to study it twice, just really get familiar with this graph and these notes right here. and understand how um, RBE and OER can change with different factors. Okay, and then I had two sections on SRS, IMRT, IORT, dose distributions, dose heterogeneity. I don't think there's anything new to learn here besides what you already know from clinic. Great, and we just have two more sections left. We're almost there. So combined modality therapy. So combining radiation with chemotherapy. Classes of chemotherapy agents. There's alkylating agents. Um, this is just the chemo review page. Um, Alkylating agents are not cell cycle specific, and they inhibit DNA or RNA synthesis. Anti-metabolites, these are cell cycle dependent. That might make sense because it's doing stuff with nucleosides, which, anyways, this interferes with DNA, RNA. It inhibits enzymes required for synthesis. Natural products like antibiotics or alkaloids, which include these drugs. These are not cell cycle specific. They interfere with DNA. And then within these, you have topoisomerase inhibitors. I thought it was worthwhile to mention that doxorubicin is a topoisomerase inhibitor, even though it doesn't have like top in the name. Who knew? Bleomycin is a kind of unique drug, binds to metal ions, including iron, to generate reactive oxygen species, which cause single and double strand breaks in DNA, and it causes pulmonary toxicity. Mitotic inhibitors, paclitaxel, stabilizes the microtubular polymer and protects it from disassembly, thus arresting cells in G2 to M phase. Don't get paclitaxel mixed up with topoisomerase. They're different. And then natural products can interfere with protein synthesis. Okay, we have endocrine therapies. Okay, and then we have some specific mechanisms of action, which are in that hood spreadsheet. But rapamycin or sirolimus mTOR inhibitor or tizimib is a proteasome inhibitor used in multiple myeloma. Cyclooxygenase or COX-2. And okay, but we've already talked about oxygen effect on radiation and chemotherapy. MDR mechanisms, multi-drug resistance. So this is probably very well known in for med-oncs. MDR are membrane proteins that send out cytotoxic drugs from living cells. So this is a big obstacle for chemotherapy. You're giving something, it's working, but then this stupid MDR protein comes into play and starts kicking out the chemo that you're trying to use. Very annoying. They are polyspecific, so they can block multiple agents. They might be transporter proteins like MDR1 or ABC transporters. Interaction and synergy of chemotherapy with radiation. So there's synergy when chemotherapy kills cells that radiation would have trouble dealing with. So some chemo agents kill hypoxic cells. Some chemo agents kill cells that are in S phase. Nice synergy. That's all. Targeted therapeutic agents. So, okay, here's where I put some of the stuff. So anything that ends in nibs uh, is a small molecular inhibitor. So nibs actually they came up with that because it sounds like inhibit. So there's tinib, which is a tyrosine kinase inhibitor. So now suddenly you know what all of these are because they end in tinib. They're all tyrosine kinase inhibitors. Um, Raffinib, these are RAF kinase inhibitors. So now you don't have to guess anymore. All of these that end in raffinib, you know, they're RAF kinase inhibitors. Um, and then this is so cool. Any nib is a substrate of cytochrome P450 enzyme. So therefore, you have to worry about drug interactions with the liver. Bonus. Which drugs are most commonly reported to cause radiation recall reaction? Answer. Doxorubicin, paclitaxel and paclitaxel, and antimetabolites gemcitabine and capecitabine. I think we've had, at least I saw some GI cases where we were treating with capecitabine and there were recall reactions. Um, okay, radiosensitizers, bioreductive drugs, and radioprotectors. We talked about therapeutic window. This is a range where the drug is providing good, effective therapy with minimal side effects. Um, Tumor radiosensitizers, oxygen, and mimics like nitroimidazole. Nitroimidazole can replace oxygen as an electron acceptor, so it mimics oxygen. Um, Interestingly, nimorazole, nitroimidazole, was used in a Dahanka trial and had minimal extra side effects. Others, misonidazole and etanidazole. I think the results of this were pretty cool, and people in Radon questions are saying, why don't we use this more? Uh, oh, look, there was a meta-analysis. Hypoxic radiosensitization, adored and ignored. Okay. Um, yeah, modifying the tumor hypoxia significantly improved the effect of radiotherapy with an odds ratio of 0.77 for local regional tumor control and 0.87 for overall survival, and ignored. Heat shock protein 90, HSP 90, a heat shock protein inhibitor leads to radiosensitization by reducing DNA repair pathways. That's not very intuitive. I thought that would have to do with hyperthermia or something, but it doesn't uh, in this sentence. Normal tissue radioprotectors. So yeah, this is a popular radioprotector, amifostine. Um, Particularly helps for blood, gut lining, and salivary glands. It's given minutes before radiation. It's lipophilic, so it does not cross the blood-brain barrier. And so it only helps protect tissues outside of the CNS. The dose-limiting toxicity is hypotension. Uh, and this is kind of how it works. Uh, has a sulfur H2 scavenges free radicals, and then um, it's selectively uptaken by normal tissues compared to tumor cells. It does not help with decontamination, though, after radiation incident. Um, so this is a difference. I mentioned like radiation mitigators. That's different than a radioprotector. Okay. Radioprotector is something you give before you give radiation. Radiation mitigator is something you give after radiation when you're like, oh dang. Um, for a radioprotector, there's a term called dose reduction factor, and that's a parameter that measures the effectiveness of a radioprotector. And that's all. Biologic response modifiers, IL-2 and interferon, nothing new to say. DNA repair inhibitors. I think all I wrote about was PARP, which we already talked about last time, but it recognizes single-strand DNA breaks, facilitates repairing them. So if you inhibit it, you allow single-strand breaks to build up and increase the risk of double-strand breaks just from the buildup of single-strand breaks. Immunotherapy. Okay, this is another important topic. So first, monoclonal antibodies, or MABs. So cetuximab, bevacizumab, trastuzumab. These are all monoclonal antibodies. Cetuximab is a monoclonal antibody against EGFR. Bevacizumab is a monoclonal antibody against VEGF. And trastuzumab, monoclonal antibody against HER2. All MABs are proteins, so they must be administered parenterally. I think this makes sense because if you eat a protein, you would digest it and then the protein wouldn't work. My simple understanding. But so you're doing, I guess, an infusion, so chances of allergic reactions are higher since you're infusing a protein. Okay. Checkpoint inhibitors now. So what's the difference between PD-1 and PD-L1? L's for ligand. So PD-L1 is going to be blocking the ligand. And then if it doesn't have L, it's the receptor. PD-1 inhibits activity of T cells in peripheral tissues. So immune suppression occurs within the tumor microenvironment because the tumor exists in some sort of peripheral tissue. And here I just have some notes. The side effects are drug dose dependent with more adverse effects with higher doses. That might be a question that you get. Here I have PD-L1, so ADA, and then PD-1 inhibitors, NPC. It's so annoying when you like see a question and you know it's immunotherapy, but then it's asking you, is it PD-1 or PD-L1? It's like, why does it really matter? But they love asking that. Okay, CTLA4, so the other big important immunotherapy, cytotoxic T lymphocyte antigen 4. T cells have CTLA4 and CD28 on their cell membranes. These can both bind to CD80 and CD86 on antigen-presenting cells, or APCs. CTLA4 has a higher affinity than CD28 does, though. So here's a picture of CTLA4, and here's a picture of CD28 and CD80, and here's CD86 is brown. So you can see that both of these are binding to blue CD80 and brown CD86. CTLA4 binding prevents T cell stimulation. T regulatory cells have lots of CTLA4 expression. That's important to prevent autoimmunity. Whereas CD28 binding leads to T cell stimulation. So signaling activates transcription factors like NF-kappa beta, NF-kappa B, and activator protein AP1, which leads to IL-2 production and T cell survival. Most of the time, CTLA4 molecules are intracellular. 90% are endocytosed, but through transendocytosis, CTLA4 extracellular expression can increase and thus modulate T cell inhibition and stimulation like a rheostat. So it can come and become extracellular. Ipilimumab inhibits CTLA4, thus preventing T regulatory cells from down-regulating the T cell proliferation immune response. So hopefully that makes sense. We have CD28, which is always trying to stimulate T cells. And then we have CTLA4, which is always trying to prevent T cell stimulation. And I mentioned that CTLA4 is like wins when it's 1v1. But if we have a CTLA4 inhibitor, these guys are out. So now you're just going to have your CD28s being rampant and uncontrolled, causing T cell stimulation. So differences between CTLA4 immunotherapy versus PD and PD-L1 blockade. Blocking CTLA4 affects early T cell activation, whereas PD-1 and PD-L1 blockade are more relevant later on in the tissue. So because it affects early T cell activation, CTLA4 blockade has more side effects than PD-1 or PD-L1 blockade. These are just some other honorable mentions. LAG3, TIM3. I don't know anything about them. Immunosuppressive medications. So the OG immunotherapy was actually immunosuppressive medications. But then once we had this new kind of immunotherapy, this has now like stolen the name immunotherapy. But if you talk to any old doctors, when they hear immunotherapy, they might remember when it was referring to immunosuppressive medications. Cytokines, vaccines, adoptive cell transfer types. I didn't have anything worthy to say about those. Combination of immune therapies and radiation. I don't know why they talk about recently published trials. I think they're just like, you should know about these, but these do not appear. Known predictors of response biomarkers. This is an evolving field. So far, we have found these factors correlate with response. So this is kind of interesting. It's like you want to know like what can predict good immunotherapy response or not. So we're trying to learn about that. I think I read in a review paper about this and filled it out with stuff I learned from that. But looking at how if there's CD8 positive and CD4 positive T cells, that's a good predictor of response. If there's PD-L1 expression, you have better response. And we see that we'll like test people for like what's their PD-L1 score. Tumor mutation burden, if it's high, there can be a better response. There's mismatch repair defects, better response. If there's an intact interferon gamma pathway, good response. Intact interferon beta pathway, good response. Immune-related adverse effects from immunotherapy. So if someone's having really bad side effects of immunotherapy, some studies have suggested that they're actually going to have a better treatment outcome, or better response, I guess. Um, and then lastly, the intestinal microbiome is probably related to response. Hyperthermia. Let's see. This is also high yield. Um, special thanks to Chris, who just see John's comment. Um, special thanks to Chris from our department who helped me with some of my hyperthermia notes. Uh, hyperthermia causes damage to DNA, proteins, and cell membranes. It interferes with the cell cycle. It impairs DNA and protein synthesis. It can have synergies with radiation. It prevents sublethal damage repair of DNA after radiation. Impairs DNA synthesis. It increases blood flow and permeability to increase oxygenation to help reduce sensitized tumors. It stimulates the immune system and anti-tumor immunity. This is another picture showing the blood vessel, and then as you get further away, you get less oxygen once you're past a certain distance. And so okay, I don't know what that says. Hyperthermia is nice because it is agnostic to whether a cell is hypoxic or aerobic, whereas radiation alone struggles to damage hypoxic cells. So when you have a hypoxic cell, it tends to be more acidic or deprived of nutrition, and that actually sensitizes them to hyperthermic killing. Furthermore, hypoxic cells tend to be further away from blood flow, so they have a slower ability to dissipate heat compared to normal tissue. That's kind of cool. It reminds me of like when Mary's talking about IR procedures in the liver, and if you're too close to like a major vessel, it'll wash away the heat. So the temperature in a tumor is often higher than in surrounding tissues during hyperthermia treatment. Does that make sense? Okay. Hyperthermia is most effective at killing S phase cells. What's the most radio-resistant phase in the cell cycle for radiation? S phase. So hyperthermia is the best at killing S phase. So that's a perfect complement. And it's least effective at killing cells in the G1 phase. Unfortunately, radiation is also not very good at killing cells in G1. So those crafty G1 cells are evading us. Thermotolerance. This is a key term. This is describing a phenomena when there's induction of heat shock proteins, which help refold denatured proteins to restore function. So these are like responding to heat and trying to make things better. They also correct folding of newly synthesized proteins to protect a normal tissue. So if you have a hyperthermia treatment of 39 to 42 degrees, you get thermotolerance in 2 to 3 hours. If you give hyperthermia treatment above 43 degrees, thermotolerance takes longer to develop. This affects our treatments and how much temperature we decide to set the treatment at. So so when we're doing treatments, we have the most radiosensitizing effect if we give it at the same time as radiation. And then on the other hand, the best therapeutic effect, where you have like tumor killing versus basically normal tissue repairing, which they've described as skin therapeutic gain factor. The therapeutic effect is achieved when you do sequential heat treatment. So this is a graph showing this total killing. I think this tumor. Okay, yeah. Let's do some color here really quick. So tumors, red line here. So we see there's like a lot of tumor killing. Oh my gosh, can't even stay on the line. So a lot of tumor killing when you give radiation at the exact same time as the hyperthermia. Whereas your skin, which is representing your normal healthy tissues, if you give radiation at the same time, you're also going to really cause damage to your skin. So they're looking at the ratio of tumor damage to skin damage. And so this is why sequential treatment is popular, so that we can cool it off a little bit. Thermal enhancement ratio. This is the last term. Respective radiation doses of radiation alone divided by the radiation plus hyperthermia dose necessary to receive equal survival curves. Okay, so the dose of radiation divided by the total dose of radiation when you're giving hyperthermia to achieve the same survival. Clinical studies have shown a thermal enhancement ratio of 1.2 to 1.6. So I asked, given this graph, do we give hyperthermia before radiation, or do we give it after radiation? Or does it not matter? What do you think? So, great question, complex answer. Based on mouse data, heating afterwards provides more skin sparing, which we sort of see here, what they refer to as therapeutic gain factor. However, the shoulder of heating first may be more favorable for timing. Traditionally, based on data and the logistics, it's better to delay hyperthermia than to have to reschedule radiation. Hyperthermia was mostly delivered afterwards. Recent data in the 1990s indicate that skin toxicity is actually not a big problem, even when delivered simultaneously. Also, the curves are for achieving high temperatures, are the dominant effect of DNA damage and repair, cell damage, etc. Now we consider that hyperthermia before radiation can be used to increase oxygenation for the radiation fraction that immediately follows. So basically, people do both scenarios. Here, we tend to use hyperthermia after radiation for large, bulky tumors where we can get good temperature elevations. And if we anticipate lower temperatures, then we might try to heat before radiation. Most cases are after radiation. When we combine with HDR, typically after fraction 1, and then after fraction 2, prior to fraction 3. There's no perfect answer. Both sequences work. Thermotolerance, acquired resistance to heat, and it's not to be mediated by the heat shock proteins, which I mentioned above. The time course of heat shock proteins appearing and maintaining things and then eventually disappearing mirrors the time course for the development and decay of thermotolerance. Okay, that makes sense. Um, so actually, okay, I think this is a good sort of final question about hyperthermia. So you probably will get on this. This is using thermal dose equivalents. So doing something for X minutes at a certain temperature represents some equivalent biologic damage produced by the treatment. So for every degree that you're above 43, that time is weighted as time times 2 raised to the temperature difference. And for every degree that you're below 43 degrees, that time is weighted less as 1/4 raised to the temperature difference. So, for example, if I had a treatment that was 1 minute at 42 degrees, 2 minutes at 43 degrees, and then 2 minutes at 44 degrees, and 1 minute at 45 degree, what's my thermal dose equivalent? So I have so 42 degrees is below 43, so I'm going to be using this formula. So I have 1 minute times 1/4 raised to the 43 minus 42. And then at 43 degrees, my thermal dose equivalent is 1. So I had 2 minutes at 43 degrees. And then I had 2 minutes at 44 degrees. So now I'm using this formula because I'm above 43 degrees. So I have 2 times 2 raised to the 44 minus 43. And then I had 1 minute at 45 degrees. So 1 times 2 raised to the 45 minus 43. And I do that, and I get 10.25 minutes at 43 degrees. That's how I would express this as a thermal dose equivalent. So if I wanted to give this treatment differently, I could simply set them at 43 degrees and do a treatment of 10.25 minutes, and that'd be the same thing as doing all this. Okay, very good. Very, very good. Last section. You guys are doing great. And then you'll be done. No more studying. Okay, so late effects, safety, and protection. Uh, this section is kind of short. It has some high yield things in it. So radiation carcinogenesis, dose response for radiation-induced cancer. After an acute radiation accident exposure, leukemia is the first kind of cancer to develop, can happen as early as 2 years after exposure. Peak incidence is 7 to 12 years, and it's safe 20 years after exposure. Thyroid cancer can begin 4 years after. The peak incidence is 7 to 10 years after exposure. Other solid tumors can begin as early as 12 years after exposure, typically 20 plus years after exposure. This is what we mostly talk about when we're when we're counseling patients, because we're not about to give patients a bunch of total body dose. And I guess if you were to be doing treatment near the thyroid, I guess in theory, they might have a chance of getting thyroid cancer sooner compared to other kinds of cancers. Cataracts. 2 gray is the threshold for single exposure. The latency period is dose dependent. So the more dose you give, the faster they'll get cataracts. It appears to progress from the subcapsular posterior region of the lens. That is important. I think, why is it important? You want to know, is it my fault or not that the person has cataracts? So they go to the doctor's office and they do their like eye exam, and they're like, it appears that the subcapsular posterior region is affected. And you're like, oh man, that was me. Okay. Cancer is a stochastic effect of radiation. Its severity is not determined, but the probability to occur is determined by radiation dose. Radiation-induced tumors tend to be expressed later in life at the time that spontaneous tumors of that tissue would have developed. So so if a young girl gets radiation to their breast, she probably wouldn't develop breast cancer until the typical age that she would have breast cancer. This might be truer for tumors that are hormone dependent. Second, tumors in radiation therapy patients. So I talked about the timing, but leukemias, AML and CML are the most common types. The risk of leukemia is somewhere around 15%. I couldn't find a source for this. I don't know if that's right. The latency period, as I mentioned, 5 to 7 years, typical. Solid tumors, yeah, latency period varies, but is a long time. And thymic radiation increases the risk of secondary thyroid cancer. Chernobyl, thyroid cancer was the most common cancer observed among children who lived in the Chernobyl area. This was the result of lots of environmental contamination with radioactive iodine, which homed to the thyroid. Children Cancer Survivor Study showed increased incidences of skin cancer, sarcoma, meningioma, and thyroid cancer in childhood cancer survivors who received radiation as part of their treatment. Risk estimates in humans. So risk of cancer lethality by radiation. So this isn't the risk of cancer death, or sorry, this isn't the risk of cancer incidence. This is a risk of cancer death. So at work, we call this occupational exposures for high dose rate kind of radiation. So like, boom, there's some instantaneous exposure. The risk of cancer lethality is 8% per gray that they're exposed. For low dose rate, so yeah, something that's and I guess you'll have the exact definition of high dose and low dose rate in your physics studying, but 4% per gray. So example, you have 1,000 nuclear power plant workers and they're exposed to 0.1 gray. How many workers will get lethal cancers? Lethal cancers. So this was a low dose rate. So 0.1 gray times 0.04 for 4% times 1,000 equals 4 workers. At home, so city was bombed, kind of example. High dose rate, 10% per gray that they're exposed. So if you had a city of 1 million people was bombed exposed to 4 gray, how many citizens will get lethal cancers? 400,000. And low dose rate, again, is half of this, so 5%. EPA estimates that 10 to 20% of lung cancer deaths in the US each year are due to exposure to indoor radon through the production of alpha particles resulting from the decay of radon to alpha-emitting daughter products. Yikes. Heritable effects of radiation. Okay. Heritable effects of radiation. DNA mutations correlates to total dose. Mutagenic hazard, 3 times 10 to the negative mutations per gene per centigrade. I don't think that came up, thankfully. Genetic doubling dose. Dose for doubling mutations, 20 to 30 centigrade for acute or 90 to 100 centigrade environmental. Heritable effects and mutations. Period at risk for expressing a radiation mutation equals 10 genetic generations. Okay. So if humans have kids every 30 years, then 10 genetic generations is 300 years. Um, and that's the risk at which you could still express a mutation from a radiation exposure. Um, risk estimates for heritable effects. 0.2% per sievert. And again, one sievert is 1 gray. It is like equivalent to 1 gray. Genetically significant dose, GSD, is 0.3 millisieverts. This is something that they calculate by weighting the individual gonad dose received from X-ray exams. Okay, the definition is described here. So they estimate that an average of 0.3 millisieverts to the gonads are the use of diagnostic X-rays. Radiation effects in the developing embryo. Dependence of abnormalities and death on dose and gestational stage. Okay, this is relevant, thinking about fetuses and pregnant patients. So this is also pretty high yield. So during pre-implantation, so this is days 0 to 9, then there's organogenesis, which is from 10 days until 6 weeks. Then there's the fetal stage, which is from 6 weeks until term. And here we can see the effects of giving radiation on fetal development at different times during fertilization. So, yeah, basically, if you radiate something during the pre-implantation phase, it can cause death with a high chance. And then once you get into this organogenesis phase, now things can live, but they'll have abnormalities. There can still be neonatal death at a certain time, but then you get into a safer range when they're in the fetal phase. I've kind of explained that here. This may as what is most likely to happen if a person gets radiation exposure to her, she's pregnant and it's like 15 days into her pregnancy. So then it would be like, is prenatal death the most likely thing, or malformation, or mental retardation, or something? So in this case, if it was like at day 15, then malformation would be most common. If she was at week 12, then like mental retardation would be most common. And if in addition, I guess up to week 15, microcephaly and growth shunting. And then if they're past week 15, then the risk of like microcephaly and growth shunting is a lot less. You still have a risk of mental retardation, but it's a lower risk. During this higher risk phase, the risk of mental retardation is estimated to be 40% per gray. And then in the later phases of pregnancy, although there's still a risk, it's lower, it's 10% per gray. Here's another handy table kind of summarizing what I've talked about. So when should you discuss with a pregnant patient if their baby is at serious risk? At a dose of 0.1 gray to an embryo or fetus, during the day 10 to 25 period. So again, this is either organogenesis or fetal period. This is a minimum dose when a physician should discuss with a pregnant patient the risk of radiation-induced birth defects, and if they should possibly have a therapeutic abortion. At doses above 0.1, you can, at doses above 0.1 during organogenesis, consider abortion. At doses above 0.2 Gray during fetal period, consider abortion. Dose threshold for mental retardation is 0.3 Gray. Childhood cancer risk increases from radiation in utero, 6% per Gray, which is also known as 0.06% per centigrade, which is a 40% relative risk increase per centigrade. I think I was just synthesizing with other numbers that we had from other parts of the studying. Okay. So here's a table also showing sort of what we just 8 to 15 weeks high risk of mental retardation, 40% per Gray. Carcinogenesis in the general population, 5%. This thing, although this is cancer lethality, hereditary effects, 0.2% per Gray. These are some, I guess, supplementary things related to this topic. I think I've talked about some of this. So I will go down. I know you're like, wait, I don't want this to end. Spend more time talking about those figures. I want to know everything. Okay, stochastic effects and tissue reactions. This was super annoying. Unfortunately, I think you might be tested on like some of this. Some of this I already talked about. But yeah, I included this just for completeness. Okay, National Council on Radiation Protection. So you're a RadOnc resident. How much dose are you supposed to have per year? You're supposed to have less than 50 millisieverts per year. What's your weekly exposure limit? Weekly exposure limits should be 1 millisievert or less. Embryo fetus exposure after the pregnancy's been declared is 0.5 millisieverts per month. So you have a pregnant woman who's working and she's asking like, how much dose can I get while I'm on the job? You have to keep the cumulative dose less than 5 millisieverts during the whole pregnancy, and you have to keep her dose per month less than 0.5 millisieverts. Public exposure limit is 1 millisievert per year. Medical students have the same limit as public. Exposure from radioactive waste materials counts towards this limit. And background and radiation exposures resulting from medical exposures that are performed to either diagnose or treat do not count towards the annual limit. So when someone gets a CT scan, it doesn't count as an annual limit. When someone gets radiation treatment, it doesn't count towards their annual limit. That's good, or else we'd be in big trouble. Tissue and radiation weighting factors. So what is a tissue weighting factor? This describes which organs are considered more sensitive to the induction of cancer or susceptibility to genetic risks. So, in other words, when someone has total body radiation, how much of that negative impact is related to a specific tissue? So you think about TBI, bad exposure. We had like GI syndrome, uh, um, so stomach and intestines have really high weighting factors. Um, we didn't talk about like people's like skin falling off. So stuff that has a lower weighting factor, brain, skin, and bone surfaces. Here's a table with some estimates of the weighting factors. When you add it all up, it should add up to 1. Um, okay. Radiation weighting factor. Dose equivalent equals absorbed dose times the weighting factor. So uh, photons and electrons are a weighting factor of 1, so the dose equivalent is just equal to whatever their dose was. Protons, you use a weighting factor of 2. Um, neutrons have a weighting factor of 2.5 to 20, and then alpha particles and heavy ions have a weighting factor of 20. This seemed like a relevant thing to know, but I don't remember coming up about this. Um, equivalent dose, effective dose, committed dose. So I just talked about what a dose equivalent is. Check. Let's see, effective dose. Effective dose equivalent is the sum of the products of the dose equivalent to the organ or tissue and the weighting factors applicable to each of the body organs or tissues that are irradiated. What does that mean? So dose equivalent inflicted on a person per year. We talked about the annual effective dose equivalent from diagnostic imaging is 3 millisieverts. That was like the weird thing where they were knowing what's the average dose a person's gonad is receiving per year. Um, partial body radiation, sum of equivalent doses to organs and tissues exposed multiplied by a weighting factor. Okay. I don't have an example of this, I'm sorry. Collective effective dose equivalent. This is effective dose equivalent per person times the population. So with a population of 300 million, like the US, the collective effective dose is 3 millisieverts times 300 million equals 900 million person millisieverts, or 900,000 person sieverts. Committed dose equivalent. So this is the dose to the same specific organ or tissue of reference that will be received from an intake or radioactive material by an individual during the 50-year following the intake. My gosh. Committed effective dose equivalent. The sum of products of the committed dose equivalents for each of the body organs or tissues that are irradiated, multiplied by the weighting factors applicable to each of those organs or tissues. The dose equivalent inflicted on a population estimating the 50-year consequence. I'm pretty sure this was kind of straight out of Radon questions, and it seemed important to know the difference between all of them, but very confusing. But I guess if you look at this long enough, you might understand it better than me. And then lastly, I think this is just repeating what I said earlier. Medical workers should be limited to less than 50 millisieverts per year, and the general public limited to less than 1 millisievert per year. Any more down to go? I think that is everything, guys. Oh my gosh. Wow. Uh, oh my gosh. Can't believe we did that.
All of Radbio.
That was everything.